morning. I'm Rajiv Saigal with UCSF Neurosurgery. I'm here with two of my colleagues, Dr. Fehlings and Dr. Yi Lu. And today we'd like to cover state-of-the-art in spinal cord injury. What's new, what's hot, what are current trends and important things for the clinician and listeners to know about spinal cord injury. First, we'd like to just start with some introductions. I'll let Dr. Fehlings go next.
I'm Michael Fehlings, Professor of Neurosurgery at the University of Toronto, and I'm Chair of the NAS Section Development Committee.
Dr. Lu?
My name is Yi Lu, and Associate Professor at the Master in Brigham, Harvard, and I'm the Director of Neurosurgery Trauma at that system. And for NAS, I'm the co-chair with Rajiv for the spinal cord injury section.
Very good. So we thought we would each talk about some of the topics that are trending in spinal cord injury. And so we'll jump right in. Dr. Fehlings, I think you wanted to say some things about timing of surgery?
Yeah, thank you. So, the concept of time is spine is continuing to gain traction. Last year we put together with AO Spine and the Praxis Institute with the collaboration of NAS some guidelines which really have indicated that there's a substantial evidence to support early surgical intervention for people with traumatic spinal cord injury. The definition of early is still under discussion, but as far as the guidelines are concerned, there's a 24-hour time window within which to undertake surgical management, but it's likely that there's a continuum of timing. There's a lot of interest in the role of ultra-early surgery. And there's, of course, a number of controversies and challenges that emerge. So we have a very heterogeneous population with spinal cord injury. We have an aging population, many of whom are medically frail, and their judgment is then required. And guidelines can't necessarily tell you how to manage an individual patient. You need to use the guidelines and apply those to the management of these patients. Later on this morning, we actually have a session here at NAS talking about the challenges in managing the geriatric patients. And one of the interesting areas that's emerging is the whole role of central cord injury. And there is emerging evidence to support a role of surgical intervention in central cord injury. And then now, there's really, I think, emerging evidence, and one of the topics that our section on spinal cord injury is quite interested in looking at is actually to collate the emerging evidence related to central cord injury and potentially to evolve care pathways and new guidelines.
Just a follow-up question on that latter topic and kind of combining the two. There was this old dogma of for the central cord patients, giving them time to cool off before bringing them to the operating room. Do you think that's resolved and there's more data to support earlier surgery for the central cords, or is it still an unresolved issue?
Yeah, I mean, the whole nomenclature of central cord syndrome is probably an unfortunate term. It's really an incomplete cervical cord injury. And, we have patients that come in with an ASIA-C injury with a very severe injury. And if you have a person who's relatively medically healthy with an ASIA-C injury, I would argue that those patients should undergo early surgical intervention as with other patients. And then you see these other patients who maybe have a neglected or unrecognized cervical myelopathy. They trip and they fall and they have a mild bump on the cord. They have an ASIA-D injury. I would say that there is a role for surgery, but there's less of an urgency there to go in at 24 hours. And I think this is kind of one of the controversies. Rajiv, I may ask you, just since we're talking about the management of acute spinal cord injury, a lot of discussion around perfusion, hemodynamic management. I know that your center at UCSF is quite interested in this. I wonder if you could maybe bring us up to speed with your thoughts on the whole concept of optimizing spinal cord perfusion.
Sure, absolutely. So I think prior to several years ago, there was not much data, and really most centers were still focusing on MAP as a metric for optimizing spinal cord perfusion without a local measure of what the pressure is inside of the spinal cord or in the intrathecal space. We have to give a lot of credit to our colleague, Dr. Brian Kwan, who's not here today, who has led a lot of the efforts in studying spinal cord perfusion pressure as a possible different target instead of having MAP goals for optimizing cord perfusion. And through some of his work, first UBC and then later other centers have adopted this technique of setting a goal of spinal cord perfusion greater than 65 instead of a MAP goal, a common choice of which would have been 85. And what we basically do for these type of patients is we place a lumbar intrathecal drain. In our case, we do that at the time of surgery. So we do it in the operating room. My preferred way to do that is to position the patient like they would be positioned for surgery anyway. Place the lumbar drain first and attach that so that we are measuring a pressure, and then start the traditional surgery standard of care. And in the postoperative period, what we do at UCSF is we go for a goal of spinal cord perfusion pressure greater than 65. Again, MAP minus the intrathecal pressure. And that can be managed with or without drainage. The CASPER protocol is something, again, that Dr. Kwan has led. We don't have the final results of that study, but that is one study to assess whether or not this different method of management may help patients. I'll say anecdotally, without knowing whether there's any change in neurological status, one thing that is sometimes easier is just the use of pressors. There are some patients who have a low intrathecal pressure where you don't have to drive the MAP as high, and then so you can wean them off pressure sooner. And then there's also, again, the option to drain some CSF to aid with achieving perfusion goals. So we are very much looking forward to finding out what data comes from the CASPER trial, and hopefully that will guide the field and help other centers decide if they want to adopt this method.
Just out of curiosity, Rajiv, so far the experience that how many patients you find of the spinal cord injury patient have high intrathecal pressure? And do you measure intra-op, and does the intrathecal pressure change when you decompress is done?
That's an excellent question. Okay, first of all, I think I have to address the point of where one measures from. So we measure by placing in the lumbar space. We generally tunnel up about 15 centimeters or so. And we just have to point out that that is an anatomically different location from where the spinal cord injury is. Okay, so we generally see intrathecal pressures anywhere from the teens to the 20s. That's a typical number range that we see. What I found is doing the laminectomy alone. A common case would, let's say, be a posterior cervical injury. We're doing a posterior cervical laminectomy infusion. What I've seen frequently is the laminectomy alone does not significantly affect the intrathecal pressure if I'm measuring that live during the surgery. However, anecdotally, I have seen that opening the dura in some of those patients and doing an expansile duroplasty does lower the intrathecal pressure. And you can see that at the moment that you open the dura, let some CSF out. If you look at the monitor, you can see that the pressure is quickly dropping the intrathecal space. So that's another interesting line along this method of thinking of how can we optimize spinal cord perfusion pressure. I'll mention on that topic that there's one ongoing trial in Europe, the DISCUS trial, to study this, that has already enrolled many patients and has, I think, a couple years left to reach their target goal. We actually are starting a trial in North America as well in 4 centers called the DATSKI trial, and we'll soon begin enrolling for that, similarly to study expansile duroplasty in a prospective randomized fashion and see if it aids. There is the other concept of whether one should measure locally at the site of spinal cord injury to have a better sense of the spinal cord perfusion. That has primarily done in the UK by the Papadopoulos group, and we'll see some of that data later when the DISCUS trial completes. Dr. Liu, I think you had some thoughts about what's new and trending in neuromodulation.
Yeah, so when we talk about what's new, what's hot now for spinal cord injury, we cannot not talking about neuromodulation. So that's one of the very hottest topic right now for spinal cord injury. And so previously our focus is a lot on the acute spinal cord injury treatment, but on the same time, there's a lot of patients, about 300,000 patients in the United States and 15 million patients worldwide with chronic spinal cord injury. And how do we manage it, how do we modulate and restore their function is a big topic. And in the past, we really don't have too much ways to increase their functions, but now with the neuromodulation, with epidural spinal cord stimulation, with potential adding on the brain-machine interface, really give us a lot of hope for restoring some of the spinal cord injury functions. We are at Master Brigham and Spalding, we're collaborating with Onward for one of the biggest trials they're starting for the epidural spinal cord stimulation. The first trial is on the blood pressure management because that seems to be one of the easier targets for epidural stimulation. And a lot of spinal cord injury patients, they suffer from also static hypotension. They have very labile blood pressure because of the injury in the spinal cord, above T6 levels. And with epidural spinal cord stimulation, at least in the initial feasibility studies, they have very dramatic response and stability of the blood pressure after the epidural stimulation. So we're very hopeful. It's a 2-to-1 blind, double-blind, randomized trial. So we're very hopeful for the study.
And along those lines, I think that another trending area has been stimulation through the skin or transcutaneous stimulation. There was a trial using technology from the same company that came out just about a year ago looking at stimulation through the skin for improving hand function in chronically injured patients. And something I see with a lot of patients that come to me is asking about the availability of those devices. And we don't yet have an epidural device available in North America. I believe this is the first trial coming to North America for a device targeted for this purpose, so it'll be interesting to see what comes of that.
Yeah, so that's one of the major limitations for people doing the study is because epidural spinal stimulation for locomotion is not a approved procedure. So that's created quite a bit challenging for people who want to do this kind of studies. So and we want to help the patient on that. So we're calling out companies who with the neuromodulation capacities to collaborate with us to push this technology forward for the patients who have suffered a lot of the chronic spinal cord locomotion deficit. And the trend is there, the hope is there, and we just need to work together to get this field moving forward.
One other different location for stimulation I just want to mention is the possibility of vagus nerve stimulation. There was a prominent paper that came out this year from Kilgard et al. That looked at vagus nerve closed loop stimulation to assess whether that could improve upper extremity function in chronically injured spinal cord patients. And before that paper came out, we really didn't have any human data. There was maybe some animal data suggesting that it could work. And there's also an FDA-approved device for a similar idea for stroke rehab. But really, we hadn't seen anything in human spinal cord injured patients. And in this study, they did show in 19 patients that there was some modest improvement in hand function using closed-loop vagus stimulation, where a physical therapist would control the stimulator and time stimulation to specific activities during rehab. So that's another emerging technology that'll be interesting to see how available it is and if it can help our patients in the future. Dr. Fehlings, you all had a prominent paper come out this year reanalyzing riluzole and whether it might be effective. Can you tell us your thoughts on that?
Yes, so riluzole is a sodium glutamate antagonist, and its most common application, and it's FDA approved, is to attenuate neurodegeneration in ALS. And so we've been studying this in a number of clinical trials, and we recently completed a trial called the RISCUS trial, which showed some promising results on secondary outcomes. we recently published in eBiomedicine, which is the open access Lancet, on a reanalysis of the RISCUS trial using a technique that really incorporates the multidimensional nature of spinal cord injury. So we're looking at impairment as assessed by motor function, but also looking at function, so looking at the spinal cord independence measure, and then combining this with health-related quality of life. And when we combine this in a multidimensional framework called a global statistical test, sure enough, we see that riluzole enhances the outcomes for patients with spinal cord injury. And so I think this is an exciting result. I think it presents an option for clinicians to be looking at, and there's a lot of interest now in doing prospective phase 4 non-controlled studies to actually assess the impact of riluzole. And in parallel with this, we've also studied riluzole in degenerative cervical myelopathy and have also found some beneficial effects perioperatively. So I think this is kind of an exciting therapy for one thing. And then secondly, I think the clinical trial methodology opens up a new dimension for us to potentially more effectively, more sensitively assess a complex disorder like spinal cord injury.
Do you think clinical trials that are being planned should use different metrics other than just neurological changes, given what you've learned with that?
I think so. So if you look at the NOGO trial that was published recently by the EMSCI network in Europe, they essentially found that you can't interpret the motor changes unless you also concomitantly look at the functional impact of this. And it's very difficult to assess a minimal clinically important difference. And I think what this multidimensional framework allows us to do is to look at an objective assessment of motor function, but then to interpret whether that actually enhances function and quality of life. So I think it's quite attractive. What's also cool is that the sample size is, when you're designing trials, is about half of what the conventional sample size might be. So there's also some conceptual advantages from that perspective. And we're actually now going to be potentially undertaking a reanalysis of some of the clinical trials that have been published using this framework. And there's a lot of discussions going on right now to see whether the spinal cord injury community will embrace this methodology.
So one of the things I want to also emphasize is the importance of the residual spinal cord tissue after spinal cord injury, especially like even for people who is with complete spinal cord motor, complete Asia B, or even Asia A patient, the residual spinal cord, people we're now realizing the importance of the residual spinal cord tissues. And there's a paper just came out from Marco Corpogrosso's group discussing the mechanism of epidural spinal cord stimulation. And from this paper, they realized the importance of the residual supraspinal control, the residual signal from the brain to the distal area of the spinal cord, even though it's not functional without spinal cord stimulation, for example. But the residual spinal cord tissue signal is very important for the epidural spinal cord stimulation function to work. So how do we targeting, like for example, the neuroregeneration studies, we have really challenging to have a very long axon regeneration from the brain all the way to the lower motor neurons. But we can certainly creating local environment to local modulation, increase the local function and the axon network circuitry in the local residual area to enhance those functions. And that can potentially increase the, for example, the efficacy of the epidural spinal cord stimulations and other tests as well.
I think this highlights the concept of combinatorial approaches, which addresses the heterogeneity of the outcomes. And what you're referencing, I think, can now be assessed in terms of tissue bridges. So if you look at some of Patrick Freund's work, it's really quite attractive. And we actually have some work coming out as well to indicate that the responsiveness to a neuroprotective agent like riluzole is dependent on the presence of these tissue bridges, which is quite interesting. So certainly exciting times in the setting of spinal cord injury.
And that's a good time to maybe just summarize and wrap up. So as we've discussed today, there's a lot of emerging areas that are very exciting for spinal cord injury. Certainly, timing of surgery is an area that we'll continue to study, and we have continued growth of evidence that early surgery may be beneficial and something we need to continue to study. In terms of spinal cord perfusion, very emerging area as to whether we should just use blood pressure metrics or also use pressure metrics inside of the spinal cord or thecal sac, and more data is needed to guide that. Neuromodulation is an exciting field that a lot of patients are aware of now and asking about, and the growth of devices that are available to our patients will help us as clinicians to treat them. And then obviously medical management, Riluzole, and many other medications have been studied, and we look for a way to combine all of these different things so that we can best treat our patients. So those are some of the topics that are emerging, and thank you for listening, and we look forward to talking to you again next time.